Hello, so good evening, everyone. Good evening. I hope my voice is audible and you can hear me loud and clear. Today is the session of 25 most expected, suspected, important questions that I feel for the subject of ENT. Some of the topics, obviously, you'll definitely know, and just in case if you're not able to solve any particular question, just add it to your notes. And with this particular note, I think I should start with this particular session. Just you have to just yeah, I think my voice is audible. Fine. So without wasting even a single precious minute of yours, I'll be starting with the session of ENT. Coming to your screen, question number 1. This is your first question. Beta, let us start. If you know, well and good. If you do not, don't worry. You just try to add it to your knowledge. Just add it to your notes. Fine. Question says, and yeah, one more thing. These 25 questions I've designed in such a way that maximum part of the subject of ENT will be revised within these 25 questions itself. Fine. So question number 1. A 40-year-old patient complained of vertigo for the last 2 months. Patient also complains of hearing loss in right ear since 2 months. Pyoton audiometry investigation was done, which suggested conductive hearing loss. Fine. This is one very important part. Patient had complaints of vertigo. Vertigo is more of a inner ear problem, beta. Fine. Then the patient had hearing loss. Fine. And now at last they are saying that the PTA gave conductive hearing loss. What shall be your most probable diagnosis, beta? I'm waiting for the answers. What shall be your most probable diagnosis? Yes. Waiting for the answers. Some are answering option number D, some are answering option number B. In fact, most are answering option number B, beta. Beta, just let me clarify some very important thing. The most important part is that in fact, most inner ear pathology gives you sensory neural hearing loss. I hope you know this thing. Any problem in the inner ear or the neural pathway, ecoli gives you sensory neural hearing loss. But this is one inner ear problem that is giving you conductive hearing loss. This is one sort of a pathology. I hope you know. And let us first see the explanation and then mark the answer. You should know this particular fact, beta. If you know, well and good. If you do not know, just add it to your notes. Beta, simple trick I have shown to your screen. If you see in that particular question that there is vertigo, along with vertigo, they are saying that there is no hearing loss. If there is no hearing loss at all, think of BPPV and vestibular neuritis. Supposedly, they say that there is vertigo also and sensory neural hearing loss, they say. Then think of the option Meniere's disease or labyrinthitis. And lastly, the rarest of the rare thing that they can ask, that there is vertigo but with a conductive hearing loss. It's a special case of a third window effect, if you know. It's a special case of a third window effect, beta. It's a very famous MCQ. In fact, I could have made it more easier and I would have asked you directly that third window effect is seen in. Then also you could have answered this particular option. But to make it more clinical, I gave you history of vertigo and conductive hearing loss, beta. This is a typical example of semicircular canal dehiscence, very common, SCCD, superior semicircular canal dehiscence. You should know, beta. If you know this thing, fine. If you do not know this thing, add it to your notes. You just have to remember these three yellow things: vertigo without hearing loss, vertigo with sensory neural hearing loss, vertigo with conductive hearing loss. That's it. Your job is done. For example, vertigo given, conductive hearing loss given. Only one option, sensory neural, this superior semicircular canal dehiscence. Supposedly, if I would have given vertigo, along with that, I would have given maybe like sensory neural hearing loss. Then you could have thought about Meniere's disease or labyrinthitis. And if I say that there is vertigo but there is no hearing loss, think of BPPV. Better remember, I remember BPPV in a very special thing, that BPPV, there is vertigo, but very importantly, there is no hearing loss. There is no hearing loss in BPPV, and secondly, there is no tinnitus, no ringing sensation also. You should know about BPPV. BPPV is benign paroxysmal positional vertigo, where there is vertigo without any hearing loss, without any ringing sensation or tinnitus. Fine. Meniere's disease will have vertigo, but sensory neural hearing loss will be there. And with a superior semicircular canal dehiscence, a third window effect, third window lesion. I hope you know this thing. If you do not know, just add it to your notes, that superior semicircular canal dehiscence or semicircular canal dehiscence gives a very famous phenomena of third window effect, which gives you a conductive hearing loss. If you remember this page, your job is done. Vertigo without hearing loss, vertigo with sensory neural hearing loss, and vertigo with conductive hearing loss. I hope it is clear. Any doubt, please ask. You should know better. This is very important. Fine. I hope this particular question is clear to all of you. If yes, I'll move on to the next question, beta. Every question that I've created in this 25 session will add to your notes. You'll add something to your notes that will help you for your FMG examination on 28th of June. Fine. I hope it is clear, beta. Fine. Now, moving on to the next question. It's a very famous question, asked number of times in NEET PG examinations, INI CET FMG examination. It's a previously year asked question, but answer this question. Which condition shall lead to maximum degree of hearing loss? Answer. Which condition shall lead to maximum degree of hearing loss? It's a known question, beta. I hope everyone answers this particular thing correctly. Perfect, perfect. Most are answering it very much correctly. They are pointing towards option number C, which is yes, definitely the correct option. Option C is definitely the correct option, beta. Yes, with intact tympanic membrane. Yes, beta, perfectly fine. You are answering it correctly. Let us see the average degree of hearing loss in various lesion. Whenever there is complete obstruction of canal, there is roughly approximately 30 decibel of hearing loss. If there is only perforation of the tympanic membrane, there is roughly around 10 to 40 decibel of hearing loss, depending on upon the size of perforation. Larger the size of perforation, more chances of higher degree of hearing loss. Third, ossicular interruption with intact tympanic membrane. It gives the highest degree of hearing loss, particularly conductive hearing loss. Highest conductive hearing loss. And lastly, ossicular interruption with tympanic membrane perforation gives lower, that is 38 decibel of hearing loss. And I hope you know the concept. If yes, well and good. If not, just I'll take 1 minute to explain the simple concept. It is simple. If this is the tympanic membrane, fine, there are ossicles which are malleus, incus, stapes. Fine. Now supposedly ossicles are supposedly interrupted. Sound wave will come from outside, strike this intact tympanic membrane, but they have no ear ossicle to transmit or go ahead. That is why higher degree of hearing loss is there. But supposedly there was a tympanic membrane perforation, no problem. Sound will directly enter inside through this perforation and hit the cochlea. The ultimate target of sound is to hit the cochlea. This is the reason why whenever there is ossicular interruption with perforation, there is lesser degree of hearing loss. I hope this concept is clear. I hope you know this concept. One more thing that I'm adding to your notes, beta. Ossicular interruption with intact tympanic membrane gives 54 decibel of hearing loss. And whenever there is fixation of stapes, remember beta, fixation of stapes, Fixation of stapes also roughly gives around this 54 to 60 decibel of hearing loss. Remember, these two, fixation of stapes and ossicular interruption with intact tympanic membrane, they are roughly producing the highest conductive degree of hearing loss. They are almost the same, 54 to 60 decibel. By mostly in your exam, both of these options, fixation of stapes or ossicular interruption, both won't be there. But if they are, I would prefer that mark ossicular interruption with intact tympanic membrane. Mostly they won't give both the options in your examination, but if by chance they give it to you, prefer to mark ossicular interruption with intact tympanic membrane. I hope it is clear, beta. I hope it is clear. Higher degree of hearing loss, always think about ossicular interruption with intact tympanic membrane. Fine. I hope it is clear, beta. With this, I'll move on to the next question. Easy question it was. It was a previously year asked question, beta. Fine. Let us think about this particular next question. Easy question. I know, I hope, I wish everyone marks it correctly. Question says that this patient with a problem inside nasal cavity presented to ENT OPD post trauma to the nose. You can see the finding. I hope you can see the finding. What shall be the most appropriate treatment for this particular patient? Answer. Yes, perfectly fine. Again, good beta. Everyone is performing fine in the ENT session. Yes, they are marking incision and drainage. Just let me explain the pathology. Yes, perfectly fine. The condition is basically septal hematoma. The condition is basically septal hematoma. What is septal hematoma? Just I'll explain it to you. See beta, what happens? Supposedly, if you can see, if you can appreciate, suppose this is the nasal septum. On both the side, there is flaps, mucoperichondrial and mucoperiosteal flap, normal thing. Now, supposedly, there is trauma to the nose and these flaps get teared or ruptured. Fine. They get teared or ruptured. Septum will get exposed. Blood vessels will get exposed. Blood will come out. That condition is called as epistaxis, bleeding from nose. But what if there is trauma to the nose? There is trauma to the septum, but these flaps do not rupture. They remain intact. Don't you think so? The blood will get collected between the septum and these flaps. The blood will get collected between the septum and the flaps. Here, the blood will get collected between the septum and the flaps. That condition is called as septal hematoma. Septal hematoma, remember my friends, is an emergency. Septal hematoma, my friends, is emergency. Why it is emergency? Because blood is collected between the flaps. Bacteria may enter inside the picture, may lead to septal abscess, and here also the problem will not stop. Septal abscess will lead to septal necrosis, and septal necrosis will lead to finally the complication, septal perforation. This is the reason why, to prevent all these complications, we have to immediately manage the case. And what is the management of the case? Just drain it out. Either do incision or drainage, or do aspiration of the blood. The blood will come out. Fine. That condition is septal hematoma. Treatment is incision and drainage. If incision and drainage is in the option, you have to mark incision and drainage. If incision and drainage is not in the option, then you can mark aspiration. Any of the two will be there in the option. Either aspiration of blood or incision and drainage. Clear? Yes. With this note, we'll move on to the next question, beta. Read the question carefully and then only mark the answer or opt for the answer. Question is, which among the following statement is correct regarding impedance audiometry? Which among the following statement is correct regarding impedance audiometry. Now in this question, impedance audiometry, I'll revise it completely for you all. Which among the following statement is correct regarding impedance audiometry? First, read the question carefully, read every option carefully, and then say the option to be marked. Options are: AS type of tympanogram is seen in glue ear. Second option, stapedial reflex is seen at a sound intensity greater than 30 decibel. Option C, stapedial reflex is seen at sound intensity greater than 70 decibel. Option D is AD type of tympanogram depicts normal hearing. Yes, everyone is answering it very much correctly, but option number C is the correct option. I'll give you the whole explanation. I'll give you the complete explanation, but fine. Let us understand this topic of impedance audiometry. Better see, simple, better simple. Impedance audiometry is an investigation which is a combination of tympanometry and stapedial reflex. Remember, tympanometry and stapedial reflex. Remember बेटा, impedance audiometry के लिए सबसे जरूरी बात, the most important thing is that the tympanic membrane should be intact. ये बात याद रखना जिंदगी में. रिमेंबर दिस फॉर लाइफ. फॉर इम्पिडेंस ऑडियोमेट्री tympanic membrane should be intact. अगर TM perforated है, if the tympanic membrane is perforated, you cannot do impedance audiometry. For impedance audiometry, the most important thing is that tympanic membrane should be intact. Now beta, it is a combination of two things, tympanometry and stapedial reflex. Stapedial reflex, only one MCQ you have to remember, that it is seen at greater than 70 decibel of sound at a high noise sound, high intensity of sound greater than 70 decibel, because whenever very high loud sound comes, stapedial muscle immediately contracts and dampens the sound. So this is the MCQ that you have to remember for stapedial reflex, 70 decibel. Just revising it with you, beta, stapedius muscle is supplied by which nerve? Anyone? Just revising it with me quickly. It is supplied by which nerve, beta? If you remember, it is supplied by nerve to stapedius, which is a branch of beta facial nerve. You should know. And just to add to your revision knowledge, ये भी बात याद रखना, there is one more muscle in middle ear, that is tensor tympani. If you know, beta, what is the nerve supply of tensor tympani? Anyone? What is the nerve supply of tensor tympani? It is supplied by anyone? 5-3, mandibular division of the trigeminal nerve. Remember, tensor tympani supplied by mandibular division of the trigeminal nerve. Just adding to your knowledge. Coming back to the topic, impedance audiometry is a combination of two things, tympanometry, stapedial reflex. Stapedial reflex के लिए मुझे एक MCQ याद रखना है, greater than 70 decibel, खत्म. Moving on to tympanometry. Tympanometry में you have to remember these graphs, which is a graph plotted with compliance and pressure. I hope you remember all these graph things better. First of all, tell me, I'll solve along with you. Type A is, what is type A? Anyone? What is type A? What is type A? Cut. But quickly. I want within these 25 questions, maximum, in fact, whole ENT should be revised. Obviously not whole, at least maximum part of the subject will be covered. Type A, but type A is normal. Okay, type A is normal. ठीक है. Now tell me type AD. बेटा this D stands for, what does this D stands for? ये बहुत बच्चों को कुछ और लगता है. What is this D? What is this D बेटा? D stands for, बेटा remember this D stands for that the graph is deep. कभी भी ये मत बोलना this D stands for dislocation. नहीं बेटा, no. D actually stands for that the graph is deep. And where it is seen, that is, yes, dislocation of ossicle. Just to help ourselves, we remember D for dislocation. Nahi beta, D actually means that the graph is deep. Yes, it is seen in dislocation of ossicles. Fine. If you know this thing, fine. If you don't know, याद रखना हाथ से. ठीक है. Coming to type AS. S stands for What does this S stands for? I know maximum populations will say S autosclerosis, but कहाँ से O का autosclerosis O और S? It is a total mismatch. What does this S stands for? S actually stands for that the graph is deep का opposite क्या होता है? What is the opposite of deep? Shallow. I knew everyone will say autosclerosis. नहीं बेटा, S का मतलब sclerosis या autosclerosis नहीं होता. S का मतलब opposite of deep is shallow. It is seen in autosclerosis. ठीक है. If आज चलो कुछ तो add हो गया, you know, add it to your knowledge. Fine, you'll remember. Fine. So yes, AS seen in autosclerosis, autospongiosis. Fine. Next, moving to the next one, that is type B. ये बेटा दिख रही है, can you see this flat curve type B seen in type B flat curve seen in serous otitis media, also called as glue ear. Type B flat curve seen in serous otitis media, also called as glue ear. हाँ बेटा, अब नहीं बोलना कि S मतलब ऑटोस्क्लेरोसिस, S मींस शैलो. ठीक है. टाइप बी सीरस ओटाइटिस मीडिया ग्लू ईयर में फ्लैट. रिमेंबर फ्लैट टिम्पेनोग्राम, फ्लैट कर्व सीन इन सीरस ओटाइटिस मीडिया. फाइन. लास्टली टाइप सी बेटा. टाइप सी इज एक्चुअली अ नेगेटिव टाइप है. मैं हमेशा ऐसे याद रखता हूं. व्हाट इज टाइप सी? टाइप सी इज अ नेगेटिव टाइप है. टाइप ए जैसे ही है बट इट हैज गॉन मोर नेगेटिव. Where do you see negative pressure inside middle ear? Only one condition you have to remember, and that is eustachian tube dysfunction. In eustachian tube dysfunction, you see a negative pressure. Beta ye dekho, pressure is negative. Negative middle ear pressure is seen in eustachian tube dysfunction. I hope the concept of impedance audiometry is clear to all of you. Fine. Chalo, very nice. Congratulations. Let's move on to the next question. Question number 5. A 35-year-old male presents with painless ear discharge. On examination, tympanic membrane shows three perforations in pars tensa and pale granulations in middle ear. PTA shows AB gap of roughly around 50 decibel. Fine. He is probably suffering from. बताओ. Answer this question, beta. Easy question. Mnemonic. It's a very famous mnemonic, beta. Easy question. Answer this question. Yes, majority of the students are answering it correctly. Yes, the correct option is tubercular otitis media. Every feature that they are showing is tubercular otitis media. I'll just show you the picture of tubercular otitis media. I remember TB otitis media by the mnemonic of 4 P's. 4 P are there. 1 P is pale granulation. Second P is multiple perforations. Remember perforations, S yaad rakhna, there are multiple perforation, multiple. Third P is profuse ear discharge. And the last P is, it is painless. And the last P is, it is painless. There is no pain. और बेटा एक चीज मेरे दिमाग में आ गई है और इसे ना यू हैव टू रिमेंबर फॉर लाइफ. वन वेरी इंपॉर्टेंट फैक्ट केम इन माय माइंड एंड रिमेंबर इट फॉर लाइफ. एक लाइन बोल रहा हूं सो दैट यू रिमेंबर. बेटा ऑल ENT कंडीशंस में TB wherever there is tuberculosis, they all are painless except for TB of larynx. Remember this for life. I hope this will help you in your clinical, when doctor ban jayenge, when we'll be seeing patients, then you'll remember my words that I would be saying right now, that I am saying right now. Remember beta, ENT conditions of TB tuberculosis are painless except for TB larynx, and that TB larynx is painful. Remember beta, TB larynx is painful, rest ENT conditions of TB are painless. Fine. Yes. ठीक है बेटा, I hope you'll remember. And beta, one very important thing, if they show you any more than one perforation, if they show you more than one perforation, maybe 2, 3, 4, whatever number, beta, think of TB otitis media only. Whenever they show you 2, 3, 4, any more than one tympanic membrane perforation, think of TB otitis media. Fine. Yes, I hope it is clear to all of you beta. This concept is clear to all of you. We'll move to a very important next question. Fine. Question number 6. A 3-year-old child presents with fever, dyspnea, and stridor. Direct laryngoscopic examination shows red swollen epiglottis. X-ray soft tissue neck shows thumb sign. The most common organism causing the above disease. I hope you know. Just answer this question. I have to clear this doubt of many of the students. What is the cause? First of all, identify the disease. Obviously, by seeing this thumb sign, you would have got what is the problem. The problem is definitely epiglottitis. And now what I'm asking is, what is the causative organism, most common organism of epiglottitis? Beta, people are answering B. How come? How come you are answering parainfluenza virus? Beta, parainfluenza is a virus. Epiglottitis is not a viral disease. What is the option that you have to mark, beta? First two तो cannot be there beta. Epiglottitis is a bacterial disease, so virus तो automatically ruled out. You just have to choose between option number C and D. Fine. Chalo. Yes, I'll clear this out for all of you. Beta, now see, there are two very important diseases that are totally contrasting to each other. On one side there is epiglottitis. Fine. And on the other side there is croup. Croup is also called as laryngotracheobronchitis. Croup is also called as laryngotracheobronchitis. Remember beta, the causative organism for epiglottitis is, beta, just remember this fact. Right now, do not mark streptococcus pneumonia. I know back 2 3 years back we used to mark streptococcus pneumonia because Haemophilus influenza vaccination was started in India. But despite vaccination, as per the latest textbooks and the latest journals also, still beta, Haemophilus influenza bacteria is more common than streptococcus pneumoniae. Don't make a mistake in this particular question. This 25 most important session will help you right now here itself. If despite knowing it right now and you make it incorrect in your exam, very wrong. याद रखना, epiglottitis is a bacterial disease. Which bacteria? Remember, Haemophilus influenza is more common than streptococcus pneumonia. Despite H influenza का vaccination start होने के बावजूद भी, the cases of H influenza are very high. It is still the leading cause. And the sign that you see here is thumb sign. Clear? On the other hand, croup laryngotracheobronchitis, for croup laryngotracheobronchitis, it is a viral disease, remember. This is a viral disease. Croup is a viral disease, laryngotracheobronchitis. Here the organism is parainfluenza virus. Here the virus is parainfluenza virus. Just adding to your knowledge, type B strain is more common than type A. Parainfluenza type B is more common than type A. It is a viral disease, better remember. And the sign that you see in croup laryngotracheobronchitis is steeple sign. Steeple sign. Steeple sign. ठीक है बेटा, epiglottitis very commonly seen in children. Obviously it is emergency situation. You have to immediately start. You would have heard about the tripod position also. Immediately we start with antibiotics and oxygen humidifiers. Oxygen humidifiers given in both the conditions. Fine. I hope this particular concept is clear to all of you beta. Remember, do not make a mistake in the organism part. Epiglottitis is the bacterial disease caused by H influenza more than strep pneumo. थंब साइन इज द साइन सीन. क्रूप में बेटा वायरस है. विच वायरस? पैराइन्फ्लुएंजा वायरस. व्हाट इज द साइन? स्टीपल साइन. आई होप दिस कॉन्सेप्ट इज क्लियर. ठीक है, with this we'll move on to the next question beta. Question number 7. Fine. Question number 7. Do not mark beta streptococcus pneumonia in that. Beta streptococcus pneumonia is still behind H influenza beta. ठीक है, let us move on to the next question beta. A 36-year-old male patient met with a road traffic accident, came to ENT OPD after 2 days. After 2 days beta, with a history of nasal trauma. Fine. On examination, patient was found to have nasal bone fracture. What shall be the management of the patient? Answer. It's a previously year asked FMG exam question, many times asked in NEET PG also. You should know this particular question beta. A 36-year-old male patient or female patient, whatever, met with road traffic accident. He or she came after 2 days. Nasal bone fracture is there. What shall be the management? What shall be the management beta? Yes. What shall be the management? The management, obviously many of the students have marked it correctly. The correct option or the correct management that you have to think about is option number beta D. Many of you would be thinking of option number C as immediate close reduction. Nahi beta. Here the crux of the question was 2 days. 2 days means 48 hours. Fine. Let me explain you the concept. Let me explain you the concept beta. Whenever there is a question of nasal bone fracture, whenever there is a question of nasal bone trauma or nasal bone fracture, the first thing is you have to check for edema or swelling. Edema or swelling. Okay? If there is no edema, no swelling, then only we have to do immediate closed reduction. Then only we have to do immediate closed reduction. I hope you know closed reduction. We do not give any incision. Just by shifting the septum and bones, we just correct the fracture. That is called as closed reduction. Fine. If there is no edema, no swelling, do immediate closed reduction beta. And if edema or swelling is present, then the management changes. Give anti-inflammatory drugs, antibiotics for 5 to 7 days, and then go for close reduction. Beta, isme do not confuse. Simple. If edema or swelling is absent, it is not there, directly immediately do close reduction. But if edema or swelling is there, then give anti-inflammatory drugs for 5 to 7 days. Wait for the edema to subside. Edema khatam hone do, then do close reduction. But beta, the examiner won't be giving you a bread and butter question like this. Okay, edema is absent. What will you do, Doctor Saab? Edema is present. What will you do? No, beta. They will generally give you time. They will generally give you time. Remember that. Beta, 2 days, 48 hours have passed. खुद सोचो, if you encounter trauma, 2 days have passed, don't you think edema would be there? Obviously edema would be there. Getting it? If they say in a question that the patient encountered trauma and immediately went to the hospital, immediately came to ENT specialist, immediately came in the emergency, then only you have to go for immediate close reduction. But if they give you time, like 1 day has passed, 2 days, 3 days, 5 days, 7 days, or whatever days, that means obviously some days have passed, time has passed, edema would be there. Because edema is there, we have to mark this particular option. I hope it is clear. बेटा whenever they give you time, एक दिन, 2 दिन, 3 दिन, 48 hours, 24 hours, patient came after some time, that means obviously swelling would be there. बेटा think about it, whenever we encounter any trauma, चोट कुछ भी लगता है, immediately 3, 4, 5 hours later swelling appears. Now 2 days have passed, obviously the swelling will be there. I hope you got the concept, beta. But remember one more added knowledge to your part. Only if the patient is coming till 3 weeks, then only we can do close reduction. But if the patient is coming after 3 weeks, like the patient encountered trauma, patient came after 1 month, patient came after 6 months, patient came after 1 year. Very commonly I encounter in my clinical OPD also. Then beta, you have to do open reduction surgery. Remember, close reduction can only be done till 3 weeks only. अगर 3 हफ्ते तक patient आ गया, then only you can do close reduction. If the patient is coming very late, maybe like more than 3 weeks, 4 weeks, 10 weeks, 3 साल, 4 साल, whatever period of time, then surgery has to be done. Concept clear? I hope it is done better. Fine. Remember this particular fact. With this, let us move on to the next question. Question number 8. Fine. Question number 8. A 28-year-old patient with history of pond bath coming from southern parts of India came with unilateral nasal obstruction and episodes of epistaxis. What shall be your most probable diagnosis? Everything has been given in the question. I'm just waiting for the correct option. Yes. History of pond coming from southern parts of India, obstruction, epistaxis. What is the option that I have to look for? Yes, majority of the students are answering it correctly. The correct answer or option that you have to mark is rhinosporidiosis. Yes, rhinosporidiosis. I'll just revise rhinosporidiosis for all of you. Beta, how I remember rhinosporidiosis? Beta, rhinosporidiosis has a letter S here. S stands for salt seawater. Next S stands for southern parts of India. South India or southern parts of India. Next S is fine. Next S is what is this? Next S, Rhinosporidium seaberry. Fine. These 3 S you have to remember: salt seawater, history of pond bath, southern parts of India, and Rhinosporidium seaberry. This is the organism, Rhinosporidium seaberry. But a Rhinosporidium seaberry, I hope you know, this is aquatic protozoa. Remember, it is aquatic protozoa. Fine. Aquatic protozoa. Okay, fine. It is aquatic protozoa. Yes. Fine. Next important thing is that you see characteristically mulberry or strawberry appearance. Mulberry or strawberry. Mulberry or strawberry. You know, any berry. In fact, I would say any berry inside the nasal cavity. If they mention mulberry, strawberry, or any berry, think of the first option, that is rhinosporidiosis. Fine. And lastly, beta, I hope you know what are these big circles. Beta, these big circles are basically the pathological thing called as spherules. Sporangia or spherules. Remember, sporangia or spherules. Fine. Lastly, what is the drug of choice? Dapsone is the drug of choice, and the main treatment or the permanent treatment is excision. You have to excise it out. Fine. I'll just revise rhinosporidiosis for all of you. Rhinosporidiosis, it is seen more commonly in southern parts of India. Salt seawater. Rhinosporidium seaberry is the causative organism. Rhinosporidium seaberry is aquatic protozoa. You see mulberry or strawberry like appearance. Fine. Dapsone is the drug of choice. Spherules are the pathological cells. And remember, the main treatment or the permanent treatment is excision or cautery at the base. They'll specifically mention history of dip bath or pond bath. That is very commonly asked thing. Fine. I hope this particular question or topic is clear. 5-6 points are there for rhinosporodosis. This topic is done. Fine. We'll move on to the next question. And yes, the very hot important topic in the subject of ENT is pyotonodimetry. This is the next question, question number 9. Given PTS suggests diagnosis of. Answer. Fine. Given pyotonodimetry suggests diagnosis of. Answer beta. Fine. Majority are answering it option number D. Fine. One student is answering Cahard's notch of autosclerosis. But the same question was asked, I think, either last to last attempt or last attempt of your FMG examination, and many students had made it incorrect because some were answering it Cahard's notch, some were answering about noise induced. Anyways, I'll clear out all the concepts of pyotonodimetry. Just listen to me. Within 5-10 minutes, you'll be clear with this concept of pyotonodimetry. Just listen to me. Fine. Simple beta. In case of pyotonodimetry, there is a graph. Fine. In that graph, intensity of sound is plotted in decibel, like 0, 10. This is my 25. 25 is important. Then 40, 60, 80, whatever. Fine. And on the x-axis, frequency is written in hertz. For example, 500 hertz, 1000, 2000, 4000 and 8000. Fine. Now beta, you'll see graphs. Basically, you'll see lines. Easiest way of solving is that you'll see two lines beta. You'll see simple two lines like this. Remember beta, one line is of bone conduction, other line is of air conduction. Let me clarify it to you. Every time bone conduction line will be above. So no confusion at all. Bone conduction line is the upper line and the lower line is of air conduction. That concept is simple and clear. I hope it is clear to all of you. Fine. Yes. Fine. So one line is of bone conduction, above line is of bone conduction and the lower line is of air conduction. Fine. Now beta, please see. ध्यान से समझना. If supposedly in the graph, suppose this is my 25, if supposedly in the graph both the lines are above normal, that means above 25, that means everything is fine, the graph is normal. The graph is normal. Fine. Supposedly in that graph, this is my 25, one line is here and the other line crosses this barrier of 25. Don't you think so? The gap has increased. This makes the diagnosis simple, conductive hearing loss. As simple as that. Just remember 3-4 things and the PTA concept will be clear. If both the lines are here above 25, that means the graph is normal. If one line crosses down, obviously air conduction line goes down, then it is conductive hearing loss. Supposedly in the graph, beta, in the graph, both the line cross this barrier of 25 and the gap between them is narrow. It is sensory neural hearing loss. It is sensory neural hearing loss. Fine. And lastly beta, if this is my 25, both the line go down also and the gap between them is high, as you can see in this, then it is mixed hearing loss. I'll revise it one more time. Simple. Suppose this is the first curve. In this, both the lines are above 25. That means everything is fine, everything is normal. Supposedly in the second curve, as you can see, one line is above 25, perfectly fine, but the other one came down. The gap between them increased. It is conductive hearing loss. Fine. Supposedly both the lines come downwards and the gap between them is narrow. It is sensory neural hearing loss. And the last is mixed hearing loss. But a mixed means both conductive and sensory neural component I have to see. In conductive, what was the feature? High gap. And in sensory neural, what was the feature I saw? Both were down. Both were down. Now I am seeing both are down also, and the gap is also high. That's why it is mixed hearing loss. I hope this thing is clear to all of you, beta. These four simple graphs will help you solve almost 50 to 60% of PTA question in split second, beta, if you know this much part only. After that only you should know the special curves. I hope you have written in your notes, because now I'll be drawing the special curves, beta. Now I'll be drawing the special curves. See, beta, I'll be now drawing the special curves. First is Carhart's notch. What is Carhart's notch? What is Carhart's notch? If you see a characteristic dip at beta 2000 hertz, a characteristic dip at 2000 hertz, that is called as Carhart's notch. There is a characteristic dip at 2000 hertz, particularly in bone conduction curve, but a characteristic dip at 2000 hertz is Carhart's notch. Beta, this was the question asked in your FMG examination. If there is a characteristic dip at 4000 hertz, a characteristic dip at 4000 hertz, beta, that is called as acoustic dip, also called by other name Boiler's notch. It is seen in noise induced hearing loss. It is seen in noise induced hearing loss. Fine. Noise induced hearing loss. Third curve is the rising curve. Better, this is a low frequency rising curve. If you see a curve going like this, rising like this, it is a feature of Meniere's disease. It is a feature of Meniere's disease. Clear, beta? If you see down sloping curve like this, going down sloping like this is a curve of old age hearing loss, presbycusis. Fine. And the last curve is a U-shaped curve, seen in congenital deafness. Congenital deafness. Fine. I'll revise these 4-5 special curves once more. If there is a characteristic dip at 2000 hertz, it is Carhart's notch of otosclerosis. Second, if there is a characteristic dip at 4000 hertz, it is called as acoustic dip or Boiler's notch, seen in noise induced hearing loss. Third is rising curve, seen in Meniere's disease. Fourth, down sloping curve is seen in old age hearing loss, presbycusis. And last, U-shaped cookie bite audiogram, seen in congenital deafness. These 3 pages will help you solve the question of pure tone audiometry. If you see in this particular question, there was a characteristic dip at 4000 hertz. As you can see, it is called as acoustic dip, also called as the Boiler's notch, seen in noise induced hearing loss. Noise induced hearing loss. Fine. This completes the topic of pure tone audiometry. I hope the concept of pure tone audiometry is clear to all of you. Fine. Almost in every 25 most important session, I discuss pure tone audiometry. Why? Because pure tone audiometry, I assure you, mostly it will come. For the last 3-4 attempts of FMG examination, pure tone audiometry is coming. I hope, and in fact, I think it will come again in the next time also. So be prepared for this topic of pure tone audiometry. Fine. Yes, moving on to the next question, beta. Yes, cookie bite is also seen in cochlear otosclerosis. Yes, perfectly fine. Cookie bite audiogram is seen in congenital deafness also, or cochlear otosclerosis. Yes, you're correct in this. Moving on to the next part, beta. Height tracheostomy is indicated in. Anyone? Answer this question, beta. Height tracheostomy is indicated in. With this, I'll revise the important topics of important points that you should know about tracheostomy. High tracheostomy is indicated in. Answer this question, beta. Some are answering option number D. Some are answering option number C. High tracheostomy, beta. Remember, beta, high tracheostomy is indicated in total laryngectomy patient. Remember, beta, whenever we are going for total laryngectomy in a carcinoma larynx patient, then only we do high tracheostomy. Let me tell you the important MCQs you should know regarding tracheostomy. Beta, first point, tracheostomy. First point is most common type of tracheostomy tube. Most common type of tube used in tracheostomy. Beta, it is Portex curved tracheostomy tube. The most common type of tube used in tracheostomy is Portex cuffed. I'll write down in capital so that the writing is also understandable. Portex cuffed. Yes, yes, yeah, correct. Yeah, high tracheostomy is done mainly. Yes, 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 yes. Perfect. For the actual site of tracheostomy, that is perfectly fine. Fine. So most common type of tracheostomy tube is Portex cuffed tracheostomy tube. Next, what are the most common indication? The most common indication for tracheostomy is prolonged intubation. This is the most common indication of tracheostomy. Next, beta, the most common complication or the complication that we are worried about is surgical emphysema. Beta, these are 5-6 points about tracheostomy that you should know. If you know, well and good. If you don't, just add it to your notes. Surgical emphysema. Next, beta, surgical emphysema, what is the most common reason? What is the most common reason for surgical emphysema? Answer is tight sutures. Tight sutures. So how will you relieve this surgical emphysema? How will you relieve this surgical emphysema? Just simple. There are tight sutures, so loosen the sutures. No, beta. Dr. Javir, the most common complication or the most serious complication or the complication in fact which we are worried about is surgical emphysema, beta. Fine. And the reason is tight sutures. Thank you, Dr. Hirsch. Yes, congratulations, you cleared your FMG exam. Fine. Let me concentrate on for the students who will clear definitely this time. Fine. Fine. Tight sutures, loosen the sutures. And lastly, the types of tracheostomy: high, mid, and low. High, mid, and low. Better remember, most commonly the type of tracheostomy we do is mid one. Most commonly that we do is mid one. Fine. Where do we do high tracheostomy? Between first and second tracheal ring. Fine. Mid tracheostomy done between second and third tracheal ring. And low tracheostomy is done between third and fourth tracheal ring. Fine. And lastly, when do we do high tracheostomy? High tracheostomy done in cases of total laryngectomy. Whenever we are planning for total laryngectomy in a carcinoma larynx patient, we do high tracheostomy. And better, low tracheostomy, remember, is done in foreign body aspiration. Foreign body aspiration. These are the points that you should know about tracheostomy. This is the common tracheostomy, cortex cuff tracheostomy tube that is shown in the image. These are the points that completes the topic of tracheostomy, beta. Fine. I hope you'll remember these important points, beta. Fine. Yes. Clear? So with this note, we'll move on to the next question. I hope the topic is clear. These are the important facts or points that you should know about tracheostomy. These are the more common or the most common MCQs that they can ask or they are asking in case of tracheostomy. Fine. Next question. Next question, beta. What is Bill's bar? Very famous question. Question number 11. What is Bill's bar, beta? Next question. What is Bill's bar? Dr. Javir is answering it correctly. Yes. Waiting for other options, beta. Anyone who is thinking about B, C or D option? What is Bill's bar, beta? Yes. Yes, perfectly fine. Perfectly. Very good. Very good. Dr. Javed, yes, and majority of the students have answered it correctly also. And he is definitely adding to the important points also. Just let me clarify, beta, what is Bill's bar? Yes, yes, yes. See, beta, there is something called as, I'll just draw it out. Beta, there is something called as this IAM. IAM. IAM stands for internal acoustic meatus. What does IAM stands for? IAM stands for internal acoustic meatus. In this IAM, there is a horizontal line, sort of an imaginary line, that is called as falciform crest. Falciform crest. Then, beta, there is a vertical bony ridge also. There is a vertical bony ridge, and this one is called as Bill's bar. This vertical ridge is called as Bill's bar. And how nerves are oriented in internal acoustic meatus, I'll just write it down for you. Here is the location of superior vestibular nerve. Obviously, superior will be superior, only superior vestibular nerve. Below that, what will be the nerve? Inferior vestibular nerve. Fine, simple. Superior will be superior vestibular nerve. नीचे कौन सी होगी? Inferior vestibular nerve. On the other side, there is cochlear nerve. There is cochlear nerve. Wait, but I'll just correct this down. Here it is facial nerve. On the other side, here it is facial nerve. Facial nerve. Here it is facial nerve. Just correct this down. And below this facial nerve, there is cochlear nerve. Fine, as simple as that. On one side, superior will be superior vestibular nerve, below it will be inferior vestibular nerve, and on the other side there is facial nerve, and below that there is cochlear nerve. I know most of the students also know how do we remember this thing. We remember just two cold drinks, beta. 7 Up. There is one cold drink called as 7 Up. Seventh nerve is above, facial nerve is above, and the other cold drink is Coke. Cochlear nerve, Coke is down. 7 is up and Coke is down. Simple. This is how you remember this complete image of internal acoustic meatus. And the most famous question regarding Bill's bar is that Bill's bar separate which nerve from which nerve? Answer is Bill's bar separates facial nerve from superior vestibular nerve. Simple beta. Bill's bar separate which nerve from which nerve? It separates facial nerve from superior vestibular nerve. This is the diagram of internal acoustic meatus. And just adding to your knowledge beta, remember this cochlear nerve, inferior vestibular nerve, superior vestibular nerve combine. Beta, this together they are called as the vestibulocochlear nerve. I hope you remember the name of the eighth cranial nerve. What is the name of the eighth cranial nerve? Auditory nerve, also called as the vestibulocochlear nerve. This superior vestibular nerve, inferior vestibular nerve, and cochlear nerve combined is commonly called as vestibulocochlear nerve, and this is your auditory nerve. I hope this concept is clear to every one of you. This is Bill's bar. You have to remember this diagram, and the concept of Bill's bar has to be remembered. Fine, clear beta? Fine. Moving on to the next question. Yes, very important. Which of the following structure passes between superior constrictor and middle constrictor muscle? This is a topic that I have combined it with the subject of anatomy and general surgery also. You would have studied it in either general surgery or ENT or anatomy. Which of the following structure passes between superior constrictor and middle constrictor? Answer. Either you would have studied in anatomy or general surgery. Yes, I have started getting the answers. The answer. Option number A is eustachian tube, second is internal laryngeal nerve, third is recurrent laryngeal nerve, fourth is glossopharyngeal nerve. Answer. Perfect. Very much correct, Dr. Javed. Yes. Yes, beta. The correct option is option number D. Yes. And what are the structures that you see between superior constrictor and middle constrictor? I'll just clarify to all of you. And these are the structures that you have to remember, beta. As simple as that. Simple, beta. Just remember between skull base and superior constrictor muscle. Between skull base and superior constrictor muscle, the space is called as the sinus of Morgagni. And what are the structures that you will see? E stands for eustachian tube. L stands for levator veli palatini. And A stands for auditory tube. Your eustachian tube or auditory tube. These are the structures. Better remember. I remember it by mnemonic ELA, E-L-A, ELA. Fine. The between the skull base and superior constrictor, the space is called as the sinus of Morgagni. The structures are ELA, eustachian tube, levator veli palatini, and auditory tube. Now, between the superior constrictor and middle constrictor muscle, there are two structures. One is stylopharyngeus muscle and glossopharyngeal nerve. Your ninth cranial nerve, glossopharyngeal, and stylopharyngeus muscle are the structure between superior constrictor and middle constrictor. Yes, between middle constrictor and inferior constrictor, the structures are internal laryngeal nerve and superior laryngeal artery. Yes, fine. Superior laryngeal artery. Fine. And lastly, below the inferior constrictor muscle, the structures are recurrent laryngeal nerve and inferior laryngeal artery. Better you have to remember, either you would have studied it in anatomy or general surgery. Very famous it is. You have to remember these structures that are present between skull base to superior constrictor, middle constrictor, inferior constrictor, and below inferior constrictor. Yes. Fine. So the correct option that we had to mark here was glossopharyngeal. Fine. Eustachian tube is present between skull base and superior constrictor. Fine. Then beta, I hope it is clear to all of you, beta. Then you had internal and recurrent laryngeal nerve. Obviously, you know between the middle and inferior constrictor, you see the internal laryngeal nerve, and below the inferior constrictor muscle, you see the recurrent laryngeal nerve. Fine. You have to remember this complete page, beta. It will help you a lot. Yes. Perfect, beta. Perfect. Congratulations. Yes. Moving on to the next question, beta. Question number 13 is on your screen. Answer. Yes. Short sign is seen in answer glomus jugular, autosclerosis, Meniere's disease, or acoustic neuroma. Answer this particular question, beta. Short sign is seen in glomus, autosclerosis, Meniere's, or acoustic neuroma. Yes. Options are coming. Option number B. Okay. Fine. Majority of the students are answering it very much correctly. Yes. Short sign, also called as the flamingo pink sign, is a sign seen in autosclerosis. Autosclerosis. But whenever autosclerosis comes, I remember like this: autosclerosis. Remember, this letter S has number of things in it. Firstly, the problem is in stapes, foot plate of stapes or stapes. Second, you see AS type of tympanogram. There are number of letter S here. Third S is Schwartz sign. Fourth S, the treatment of choice. Fourth S is the treatment of choice, that is surgery. And the name of the surgery also starts with S, that is stepidotomy or stapedectomy. Fine. But Dr. Javed, drug of choice, I'll clear this out. Drug of choice for autosclerosis is not sodium fluoride. Drug of choice for autospongiosis, which is a precursor stage of autosclerosis, for that sodium fluoride is a drug of choice. I'll clear it out. No worries. Fine. You have to remember all of these points for regarding autosclerosis. Just to revise important topics of autosclerosis, important points of autosclerosis. Remember, it is bilateral, more commonly seen in females. There are two important risk factors. One is pregnancy and measles. Obviously, hereditary transmission is there. Fine. Next, beta, there is something called as Van der Hoeve syndrome. If you know, beta, what is Van der Hoeve syndrome? Van der Hoeve syndrome, there are three departments in it: ENT, ophthalmology, and orthopedics. It is a combination of autosclerosis with blue sclera with osteogenesis imperfecta. Autosclerosis with blue sclera and osteogenesis imperfecta. This is the triad of Van der Hoeve syndrome that you particularly see in autosclerosis. Now, beta, can anyone tell me the site of autosclerosis? I am waiting for the answer. This is something very important. Can anyone tell me the exact site for autosclerosis? Waiting for the correct option or the answer. I hope everyone answered that. What is the site? If this question is asked, what is the site of autosclerosis? What is the exact site of autosclerosis? Anyone? What is the exact site of autosclerosis? Fine, Dr. Javed is answering foot plate of stapes. Foot plate of stapes, okay. Can anyone tell me even more better option than foot plate of stapes that has been asked in NEET PG and INICT, and FMG exam is also waiting for that option to come? In my regular classes also, I used to say that if this option comes in your options, mark this option because that one is a better option. Better remember, obviously foot plate of stapes, conventionally foot plate of stapes is a very much correct option for for this autosclerosis. But remember, if there is one option called as fistula antefenestra, fistula antefenestra, it is a better option than foot plate of stapes. Remember this word, these two words, in fact, fistula antefenestra. Fistula antefenestra. Yes, Dr. Jav, fistula antefenestra. It is a better option than foot plate of stapes, but majority of the times in your examination, this option won't be there. So obviously you will mark foot plate of stapes. But if fistula antefenestra and foot plate of stapes both are in the option, then fistula antefenestra is a better option than foot plate of stapes. This is as per the latest, in fact, not the latest, always, all the time, fistula antefenestra is a more appropriate site. Fine. So obviously foot plate of stapes, but for this fistula antefenestra is a better option. Then moving ahead, it is absolutely painless, bilateral. There is only mild hearing loss, and you see something, a very famous feature called as paracusis willis. But what is paracusis willis? Patient hears better in noisy surroundings. Patient hears better in noisy surroundings, that is paracusis willis. Fine. Apart from that, because obviously it is not an inner ear problem, so tinnitus and vertigo are almost not there, very rarely they are seen. Apart from that, you'll see a Schwartz sign or a flamingo pink sign. What is Schwartz sign of flamingo pink? It is shown here. It is a pinkish appearance of tympanic membrane. Pinkish appearance of tympanic membrane. Fine. Pinkish appearance of tympanic membrane. Then beta, there is a characteristic dip at 2000 Hz in pure tone audiometry, and that is called as Cahart's notch. One more added revision points. Now coming to the treatment, just to explain it to all of you who are listening to you, beta, what actually happens in autosclerosis, just listen to me. This is a normal lamellar bone. A normal lamellar bone changes into a sclerotic bone in case of autosclerosis. Sclerotic bone. Fine. A normal lamellar bone is changing into a sclerotic bone, zigzag like this. And if this sclerosis happens, it is almost irreversible. Surgery has to be done. But what happens in that female when that lamellar bone is changing into sclerotic bone? Listen to me very carefully. When that lamellar bone is changing into sclerotic bone, the body tries to protect that she shouldn't land up into sclerosis. So a transient active phase will come. Transient active phase will come. That transient active phase is called as otospongiosis. That transient active phase is called as otospongiosis. And beta, it is this otospongiosis active phase where you see Schwartz or flamingo pink sign. First of all, remember that. And in this transient active phase otospongiosis, only this medication called as sodium fluoride will work. If you give sodium fluoride in this transient active phase of otospongiosis, her autosclerosis is arrested. Then only she will not land up into sclerosis. So remember, my friends, this transient active phase otospongiosis only, you see these two signs, Schwartz sign, flamingo pink sign, and the medication sodium fluoride will work here only. But what happens, most of the females don't even get to know that they are having otospongiosis or sclerosis. Days will pass and she will ultimately land up into autosclerosis. Now if sclerosis happens, no role of medicine, treatment is directly surgery. I hope, Dr. Javed, it is clear to you, in fact clear to all of you who are listening. Fine, beta. This is the concept that you should know, and it is something very important. But most of the times, just to concise our notes or knowledge, we do not study much about otospongiosis. We just remember autosclerosis, autosclerosis, or autosclerosis. Fine. So remember, there is a transient phase that comes in the life of that female who is landing up into autosclerosis, and that is called as otospongiosis. In that transient active phase autospongiosis, the sodium fluoride medication will work. Sodium fluoride will not work in autosclerosis. It works only in autospongiosis. Clear, beta? And in this autospongiosis, because it is active, lots of blood vessels, activity, inflammation is going on. That's why the tympanic membrane turns pink and you see a Schwartz or a Fleming pink sign. Clear to every one of you? Yes. Remember, the treatment of choice for autosclerosis is not medicine, it is surgery, stepidotomy or stapedectomy with prosthesis, obviously. With prosthesis. Clear? Fine. Moving on to the next question, beta. Moving on to the next question. All are true statements for laryngomalacia except. Answer this particular question, beta. All are true statements for laryngomalacia except. All are true statements for laryngomalacia except. Answer this. Anyone, beta? Yes, majority of the students are answering it correctly. They are going for option number D, turban shape epiglottis. Yes, the correct option that you have to think about or look for is TB, turban shaped epiglottis. But this is the except thing that they are asking. First of all, let us clear out the points regarding what laryngomalacia. Whether is it the most common congenital anomaly of larynx? Yes. Presents with flaccid floppy larynx? Yes. Stridor decreases with prone position? Yes. Turban shaped epiglottis? No. But here you see a omega shaped epiglottis, omega shaped epiglottis. So remember these points for laryngomalacia. It is the most common cause of, in fact, it is the most common congenital anomaly of larynx. And added to your notes, it is the most common congenital cause of stridor. And beta, if you know what type of stridor it is, inspiratory, expiratory, or biphasic, remember beta, it is inspiratory stridor. It is inspiratory stridor. Fine, it is inspiratory stridor. Yes, next beta, whenever laryngomalacia patient comes with inspiratory stridor, the immediate treatment or the management is, I hope you remember the treatment beta, it is reassurance. You just have to counsel the parents that everything is fine, you no need to worry, everything will be fine. Whenever any episode of this stridor comes, just make your child into prone position. As soon as you make the child into prone position, that floppy flaccid epiglottis will fall down because of the effect of gravity, airway will open. Simple. Stridor decreases with prone position, remember that. Stridor decreases with prone position. Treatment is reassurance. What type of epiglottis you see? Remember beta, omega shaped epiglottis we see. Omega shaped epiglottis we see. Fine. Omega shaped epiglottis we see. And better, just if anyone knows, this reassurance is till what period of time? Till when can we say that everything will be fine, everything we what is the maximum waiting period of time? Till the parents, to the parents we have to say, everything is fine, no need to worry. Remember that maximum period of time is 2 years. We just have to wait maximum till 2 years. Fine. We just have to wait maximum till 2 years. Maximum till 2 years. Fine. Because if after 2 years the problem is there, then we have to go for surgery. Whether supraglottoplasty is the common or epiglottopexy is the surgery. Obviously, this is not very commonly asked, but maximum waiting period of time is 2 years. Fine. Clear, beta? These are all the points regarding laryngomalacia. Acha, beta, remember one thing. This turban shaped epiglottis is seen in TB larynx. In fact, for TB larynx, remember three important points. One is turban shaped epiglottis. Second, beta, mouse or moth nibbled larynx. First point, second point, and the third point is it is painful. Just remember these 3 points regarding TB larynx. First is turban shape, T for TB, T for turban shape epiglottis. Second, mouse or moth nibbled larynx. And the third is it is painful. I told you all ENT conditions of TB are painless except for TB larynx, which is painful. Just some questions before I told you that all TB conditions of ENT are painless except for TB larynx, which is painful. Fine. So these three are the important points that you have to remember regarding TB of larynx. Yes. Lymphadenopathy to beta obviously will be seen, and for TB beta remember posterior cervical lymph nodes are the most commonly involved thing. Anyways, we'll move on to the next question beta without wasting even the most one precious minute of yours, because the exam is very near. I just do not want to waste even a single minute of yours. Next question. What type of tympanoplasty is depicted in the picture? Answer this question beta. Previously asked question, it has been asked many times, and beta I think last to last attempt direct same image came in your examination. Exactly same image came. I will just magnify this image so that you answer this question. You just see where is the graft being kept and then answer what type of tympanoplasty is this. Check where is the graft being kept and then answer what type of tympanoplasty is this. It is a previously year asked FMG exam question, last to last attempt. Type 1 tympanoplasty, 2, 3, 4. Majority of the students are answering it as type 3. Fine, I'll just clarify it to all of you. Yes, the correct option or the answer that you have to think about is type 3 beta. Type 3, this is the correct option. Just I'll explain you the types of tympanoplasty. Better remember, suppose this is the tympanic membrane. This tympanic membrane is perforated. This tympanic membrane is perforated. After this tympanic membrane, there are ear ossicles malleus, incus, stapes, oval window, round window. I just remember mesor. Malleus, incus, stapes, oval window, round window, mesor. Now beta, if I am keeping a graft over malleus, this is type 1 tympanoplasty called as myringoplasty. This is type 1 tympanoplasty called as myringoplasty. If I am keeping a graft over incus, fine, if malleus supposedly is absent, if I am keeping a graft over incus, this is type 2 tympanoplasty, myringo-incudopexy. See the word incus, I am keeping it over incus. If I keep the graft over stapes suprastructure, then it is type 3 tympanoplasty called as myringo-stapedopexy. Myringo-stapedopexy. Suppose stapes suprastructure is absent, then where will I keep the graft? think about it. If suprastructure is absent, stapes has two parts. What are the two parts of stapes? Suprastructure and the second is foot plate. I'll keep the graft over foot plate. This is type 4 tympanoplasty on foot plate. Fine. If all the ear ossicles are absent, where will I keep the graft? I can keep the graft either over the oval window, round window, or better is I'll keep the graft close to a semicircular canal, lateral semicircular canal or superior semicircular canal, more commonly semicircular canal, and that is called as type 5 fenestration surgery. I hope it is clear. You just have to remember MES or malleus incus stapes, oval window, round window. If I'm keeping it over malleus, type 1 tympanoplasty. If I'm keeping over incus, type 2. If I'm keeping over stapes suprastructure, type 3. If I'm keeping over stapes का second वाला part, foot plate, type 4. Lastly, if I'm keeping it over semicircular canal, close to orifice semicircular canal, fenestration surgery. Fine. Yes, shielding effect. Yes, beta. Fine. So, beta, now if in this picture you see whole stapes is present, whole stapes is present, whole stapes is present, I am keeping it over stapes. That means it is type 3 tympanoplasty, and this was the same image that had come in your FMG examination 2 attempts ago, beta. Very important is the classification of tympanoplasty. This was given by very famous person called as Fulstein. And beta, what is the most common type of graft used? Remember, the most common type of graft used is temporalis fascia graft. Temporalis fascia graft. Yes, type 6 is sono inversion, but sono inversion beta very less commonly asked. Anyways, you have to remember. Fine. Most common graft use is temporalis fascia graft. Clear? ठीक है बेटा. Fine. We'll move on to the next question. Question number 16. Very famous question. Answer this question, beta. Best screening procedure for a preterm neonate child born in ICU is? Answer this question, beta. Best screening procedure for a preterm neonate child born in ICU. What do you think? Best screening procedure for a preterm neonate child born in ICU. Majority are answering A, some are answering option number B. What do you think? But yes, if you see, you should focus that there is a complicated situation mentioned, that the child is not a normal newborn child, it's a preterm child born in ICU, kept in ICU, NICU. But what is the investigation or screening procedure of choice in that complicated situation? It is BERA. Beta, OAE is a screening procedure of choice in a normal newborn child. Remember, OAE is the screening procedure of choice in a normal newborn child. But if there is any high risk baby, NICU baby, preterm, premature birth, any complicated thing, meconium aspiration, any complicated thing mentioned in the question, then beta BERA becomes the investigation of choice or screening procedure of choice. Fine. Just to clarify these points, this is the page that you have to remember. For newborn screening of hearing, remember, what is the screening procedure of choice in general for a normal newborn child? For a normal newborn child, the screening procedure of choice is OAE. OAE stands for otoacoustic emission. Fine. What are the important points that you should know regarding OAE, beta? Remember, when should OAE be done? It should be done after 24 hours or first day of life. Beta, never say within 24 hours. No, beta, within the first 24 hours of life, the most important thing for the child is the colostrum milk that contains IgA antibodies. That is more important for the child rather than me checking whether the child can hear or not. Okay? Immediately after 24 hours of life or first day of life, OAE should be done. Fine. Mataji says, okay, sir, I forgot to do the OAE of this particular child. I forgot to go to the ENT specialist for this OE, and my child is now 1 month old. Can I do OE? Yes, Mataji. Till first month of life also you can go for OE. Supposedly Mataji says, sir, my child is 3 months old. Can I go for OE? No, Mataji. Now better you go for BERA. Remember these 3-4 important points. Beta, OE is the screening procedure of choice for normal newborn child. It should be done after 24 hours or first day of life. Fine. It should be done till at least 1 month of life. Supposedly the child is 3 months old. Can we go for OE? You can, but better is go for BERA. These are the 2-3 important MCQ points that you should know for a normal newborn child. Remember, these are for a normal newborn child. Fine. But remember, if in that question they say that there is a child born in ICU, a high risk baby, NICU baby, meconium, any complicated thing they mention, preterm, premature birth, or whatever, then beta, directly BERA becomes the screening procedure of choice. Fine. This is the topic of newborn screening of hearing. You should know all these important points, beta. Fine. Yes, moving on to the next question, beta. Again, a previously year asked MCQ from your FMG examinations, also asked in NEET PG also. Answer this question. Identify the structure marked with yellow arrow. I'll just magnify the image. You can see two orifices, beta. One orifice is here. One orifice is here. I am asking this yellow one. Tell me. I'm asking this yellow one. Answer. What is this? Fine. Majority of the students are answering it as option number C, that is fossa of Rosenmüller, and yes, it is the correct option. Fossa of Rosenmüller is the correct option that you have to look for. Better remember, just to add to your knowledge, remember that there are two openings, as you can see. One is here and the other one is here. If you see that there is something S written over here, better, this S actually stands for septum, nasal septum, the posterior part of the nasal septum. If you see which is more close to the nasal septum, which is more medial, which is more close to the nasal septum, that is fossa of Rosenmüller. Fossa of Rosenmüller. And which is more away from the septum, more lateral. What is this lateral opening? This lateral opening is eustachian tube opening. So what my point is, supposedly this image based question comes in your examination. Two orifices are shown. You have to identify which is fossa of Rosenmüller or which is eustachian tube. Just remember, try to identify septum. Where is septum? The opening which is more close to the nasal septum, which is more medial, is fossa of Rosenmüller, which is more away or lateral is eustachian tube, and in between the structure is torus tuberous. Between these two openings, this bulged part is called as torus tuberous. Fine. Torus tuberous. This middle bulged part is called as torus tuberous. Fine. What is the important, why this fossa of Rosenmüller is very important? Fossa of Rosenmüller is very important because of this particular disease called as NPC. NPC stands for nasopharyngeal carcinoma. Just 4-5 important points regarding nasopharyngeal carcinoma. First is, it is a highly radiosensitive tumor, beta. Highly radiosensitive malignancy associated with a virus which causes your kissing disease, infectious mononucleosis also, that is your Epstein-Barr virus. It is associated with Epstein-Barr virus. What is the location? Location is fossa of Rosenmüller. fossa of Rosenmiller. And lastly, in this NPC nasopharyngeal carcinoma, you see a very characteristic triad, that is your Trotter's triad, which is a combination of NPC, neuralgia, palatal palsy, and conductive hearing loss. Yes, it is more commonly seen in the northeast part of India, or particularly the Chinese population, the eastern side of Asia. Fine. Answer this question, beta. What is the most common presentation? What is the most common presentation of nasopharyngeal carcinoma? Anyone? Better remember, the most common presentation of nasopharyngeal carcinoma is neck nodes or neck swelling. Very famous question. Neck nodes or neck swelling. This is the most common presentation of nasopharyngeal carcinoma. And lastly, what is the treatment, beta? Better remember, chemoradiation is better than radiotherapy. These 5-6 are the important points regarding your nasopharyngeal carcinoma. Treatment, chemoradiation is better than radiotherapy. Fine. So these 5-6 points you have to remember regarding nasopharyngeal carcinoma. Very important. Better remember, this palatal pulse is ipsilateral. Yes. Fine. With this, moving on to next question, question number 18, beta. Answer this question, beta. Easy, simple question. A 2-month-old child developed stridor and persistent dyspnea. CT scan and flexible endoscopy reveals subglottic stenosis of approximately 68%. What shall be the Cotton-Mayer grading of this patient? Answer, beta. If you know regarding the subglottic stenosis Cotton-Mayer grading, fine. If you don't know, just add it to your note. Simple. Answer. If you know this Cotton-Mayer grading of subglottic stenosis, fine. If you don't know, we'll just add it to your knowledge. Fine. Beta, for subglottic stenosis, first of all, I'll tell you the answer. The correct option of the answer is option number B, beta. It is grade 2 right now. Fine. Just to add to your knowledge, this is the subglottic stenosis classification given by Cotton and Mayer. Please see. For subglottic stenosis, Cotton and Mayer gave a classification where they divided it into 4 grades, grade 1, 2, 3, 4. What is grade 1? 0 to 50%. Remember beta, 0 to 50% of obstruction is grade 1. 51 to 70% of obstruction is grade 2. 71 to 99% of obstruction is grade 3. 100% total obstruction is grade 4. Remember this. 0 to 50% obstruction is grade 1, 51 to 70 grade 2, 71 to 99 grade 3, 100% total obstruction grade 4. In the question, 68% was the question asked. 68% will lie exactly here in grade 2. So the correct option of the answer that you have to mark is grade 2. I hope this particular concept is clear. Remember this classification for subglottic stenosis, Cotton-Mayer grading. Yes. If you ask me clinically, Dr. Javer, at the hospital where I perform surgeries, but for all we go for endoscopic approach only. But obviously in the textbooks they say for 1 and 2 we go for endoscopic, and for the other 2 we go for open approach. But yes, fine. In the hospital setup we prefer every time endoscopic approach only. Yeah. Moving on to the next question, beta. Moving on to question number 19. A 8-year-old child underwent tonsillectomy. After 8 hours of surgery, an intern who recently cleared his FMG examination with flying colors observed bleeding from the mouth of the child. What shall be the best step of management that this intern should do? Think about the correct answer, beta. What is the thing that you will be looking for? Option number A, continue with IV antibiotics as the child is already admitted. Option B, inform the ENT specialist that the child shall be planned for re-exploration. Option number C, ask the child to swallow the blood and say to him, don't worry, everything is fine. Option number D, immediately start with oral antibiotics and oral mouthwash. Yes, fine. Majority of the students are answering option number B. Yes, it is the case of reactionary hemorrhage within 24 hours. 8 hours is within 24 hours. The child has to be immediately planned for re-exploration. Perfectly fine, beta. Congratulations. Most of you are answering it correctly. Just let us revise the topic of hemorrhage after tonsillectomy. Just remember, obviously the most important source for tonsils is tonsillar branch of facial artery. But the vessel that bleeds is not the artery, beta. Remember, the vessel that most commonly bleeds is the paratonsillar vein. It is the paratonsillar vein. The vessel that bleeds during tonsillectomy is the paratonsillar vein. Remember, hemorrhage in tonsillectomy is classified into primary, reactionary, and secondary. What is primary? Primary is bleeding happening during surgery. What is the reason? Anyone? Can anyone tell me what is the reason for primary? Obviously, which vein is bleeding? Paratonsillar vein is bleeding. So the treatment to it is, what is the treatment? Ligation. Ligation of the vessel. Fine. Coming to reactionary, better, what is reactionary hemorrhage? Reactionary hemorrhage is bleeding happening within 24 hours of surgery. Beta, what is the reason? Can anyone tell me what is the reason? Yes, it is slippage of sutures or ligature. Slippage of sutures or ligature. Fine. What is the treatment? Immediately plan for re-exploration. Immediately plan for re-exploration. For reactionary, re-exploration. Immediately take the child inside OT, see where the bleeding is happening and correct it down. Fine. And lastly, what is secondary hemorrhage? If bleeding is happening maybe after 4-5 days of surgery, what is the cause? Infection. What is the treatment? IV antibiotics. Beta, never say oral antibiotics. How can you think कि child के मुंह से खून निकल रहा है, the child is bleeding from the mouth and you ask him to swallow his blood and take tablet and water? No, obviously not. IV antibiotics. For secondary hemorrhage, the treatment is IV antibiotics. Fine. This is the topic of hemorrhage and tonsillectomy. Fine. Moving on to the next question, question number 20th, beta. Moving on to the next question, question number 20th. Answer this question. Bryce sign is seen in. Bryce sign is seen in. Bryce sign is seen in. Answer. Yes. Yes, people are answering it very much correctly. Yes. Fantastic. Congratulations. Yes, laryngocele is the best correct option. Bryce sign is the hissing sound on pressing a laryngocele, and that is called as Bryce sign. Beta, remember, for post-cricoid laryngeal carcinoma, the sign that you see is called as the Bocas sign. Fine. For laryngocele, you see Bryce sign. For carotid body tumor, the sign that you see is Liar sign. You should know all these three signs: Bocas, Bryce, and Liar. But what is this Liar sign? Simple, just I'll explain it to you. If this is the common carotid artery, it divides into internal carotid artery and external carotid artery. Here in between is the location of the carotid body tumor. So if the tumor grows in size, these vessels will get more separated, more separated, more separated. This is called as the Liar sign. Fine. I'll explain other two signs also. First of all, look at laryngocele. Laryngocele is seen in two professions. One is trumpet blowers and glass blowers. Because of excessive air pressure, the air goes inside the saccule of larynx. Air goes inside, air in saccule of larynx. Air inside saccule of larynx is called as laryngoscene. If I press that laryngoscene, it will produce a hissing sound, and that is called as Bryce sign. Fine. I hope these two signs are clear. One is liar, second is Bryce, and the third I'll explain it to you, Boca. What is Boca? I'll explain it to you. What is Boca? Beta, everyone do like this. If you do like this, keep this over your laryngeal framework, over your larynx, push it backwards and move it sideways. Try doing it. Try doing it at your home. Push it backwards and move it sideways. You'll feel a cut grating sensation. You'll feel that cut grating sensation. If you're feeling that grating sensation, congratulations, you're fine. If you're not feeling, then better there is a suspicion of laryngeal carcinoma. Fine. Better this sensation that you, when you're pushing your larynx backwards and moving it sideways, that grating sensation is called as laryngeal crepitus. Laryngeal crepitus is normal. It is also called as Moore's crackle. But if this laryngeal crepitus is absent, it is a sign called as the Boca's sign. Fine. Absence of laryngeal crepitus is called as Boca's sign. Remember, it is seen in laryngeal carcinoma extending to post-cricoid region. But Dr. Javi, you are asking how to differentiate Boyce and Bryce. But Boyce is a Zenker's diverticulum. See, Zenker's diverticulum is more of an esophageal pathology. Fine. And mostly what happens in Zenker's diverticulum, along with air, there is little bit of food and water also. So whenever you press the swelling of Zenker's diverticulum, mostly halitosis, food and water, all of these contents will come out, and this produces a gurgling sensation, and there food or water may also come out. But on the contrary, Bryce is only pure air. That is pure larynx thing. Bryce is a laryngoscele, larynx thing. Boca is a pharyngeal thing. लोकेशन ही डिफरेंट है, एंड लैरिंग्स में ओनली एयर, और उसमें एयर वाटर फूड तीनों will come back. I hope it is clear. Fine. So these three signs you have to differentiate. Remember this. Liar sign is playing of the vessels. Laryngoscele is Bryce sign, pure hissing sound. Beta hissing और gurgling में भी difference है. Laryngoscele is pure hissing sound on pressing a laryngoscele, because only air is coming out. Zenker's diverticulum का Boyce sign is gurgling. Gurgling means water, food, air, every particle is coming out. And lastly, beta absence of laryngeal crepitus is called as Boca's sign. It is something very important that you should remember. Fine. All these three signs have to remember, beta. Fine. Moving on to the next part. Beta, easy question. It is a very famous topic. I hope everyone answers this correctly. I hope everyone answers this correctly. I hope everyone answers this correctly. A known topic, beta. A 14-year-old boy came with recurrent profuse epistaxis. Radiological image is shown. Identify the disease. Famous thing, beta. Famous question. Answer this. What is the signs? Yes, yes. Majority of the students have started answering it correctly. Yes, it is the famous Hallman-Miller sign. It is the famous Hallman-Miller sign, exclusively seen in boys, and the disease is JNA, juvenile nasopharyngeal angiofibroma. Just to add to your knowledge, these are 5-6 points that you should know regarding JNA. First of all, sphenopalatine foramen is the most common location of juvenile nasopharyngeal angiofibroma. It is the location. Fine. It is exclusively seen in boys. A teenager boy, if they mention, it is exclusively seen in a teenager boy because this tumor is testosterone dependent. Testosterone dependent tumor. That's why it is exclusively seen in boys. It is a highly vascular tumor. It bleeds a lot. So can you do biopsy? Absolutely no, sir. Biopsy is contraindicated. Biopsy is contraindicated. Now beta, the sign that you are seeing here is called as a Hallman-Miller sign, also called as the antral sign. What is this sign? As you can see, anterior bowing of the posterior wall of maxillary sinus is happening. This is called as the Hallman-Miller or antral sign. There are two staging of it. One is Radowski and Fish. But a Radowski name is very famous. It has been asked in NEET PG also. Fine. I'm quickly revising the points of GNA. Next beta, it is many a times called as the dumbbell shaped tumor because of its growth to pterygopalatine and infratemporal fossa. Fine. It is also called as the dumbbell shaped tumor because of its growth to pterygopalatine and infratemporal fossa. Biopsy is contraindicated, remember that, and CT scan is the investigation of choice. Fine. Remember these things. Clear beta? And lastly, the main modality of the treatment is surgery, and before doing surgery we do embolization of one artery called as maxillary artery. Preoperative embolization of maxillary artery. Yes, fine beta. These are 5, 6, 7 important points of juvenile nasopharyngeal angiofibroma. I'll revise it with you. First is testosterone dependent, exclusively seen in boys. Biopsy is contraindicated. Sphenopalatine foramen is the most common site. Hallman-Miller or antral sign is seen. Frog face deformity is also seen. Fine. Radowski and Fish are the staging, and it's a dumbbell shaped tumor. Surgery is the treatment of choice. Before doing surgery, we do embolization of maxillary artery. Fine. I have done it quickly, but when you will be seeing, you can see this video once again. These are 7, 8 points. JN is completed. Fine. Yes. Fine. Moving on to the next question, beta. Moving on to the next question. Question number 22. A young patient complains of nasal obstruction. Beta, very nice question. Try to answer this question. Nice question. A young patient presents with complaints of nasal obstruction, came to ENT OPD. On examination, it was found that there were yellowish greenish crust inside the nasal cavity and the nose felt hard also on palpation. What could be the probable cause? Answer. What could be the answer? In fact, I think in all these 25 questions, this is the most tricky question that I would have asked. Majority of the students have answered it as option number A, but beta, the correct answer is actually option number C, rhinoscleroma. I'll explain it to you so that you remember this concept once and for all, because the examiner will also play it with you. Better try to understand. Please see. Just understand, listen to me. First of all, look at atrophic rhinitis. But atrophic rhinitis is caused by which organism? It is caused by Klebsiella ozoniae. It is caused by a variety of Klebsiella called as Klebsiella ozoniae. Klebsiella ozoniae. Remember, this Klebsiella causes it. Fine. You characteristically see merciful anosmia, and the treatment of choice is the not the treatment of choice, the antibiotic of choice. The antibiotic of choice is, if you know, it is streptomycin with tetracycline. What is the antibiotic of choice? Streptomycin with tetracycline. In my regular class also, I repeat this fact every time. Beta, for all the Klebsiellas, not only Klebsiella ozoniae, for all the Klebsiella, the drug of choice is streptomycin with tetracycline. Along with that, you should know something called as alkaline nasal douche that we use, which is sodium chloride with sodium bicarbonate with sodium biborate. Sodium biborate in the ratio of, I hope you remember the ratio also, 2 is to 1 is to 1. What is 2? Sodium chloride is 2. Fine. And finally, coming to the treatment of surgery, surgical modality is Young's or modified Young's operation. Young's or modified Young's operation. This is the surgery that we do. The latest advance, if you ask me the latest advance, these two are the latest advance: injection Teflon and Lawton's laser surgery. These are the two latest advance. That is it for atrophic rhinitis. Merciful anosmia, 5 points, 5 or 6 points. First is Klebsiella ozania is the causative organism. That's why it is also called as ozania disease. Merciful anosmia. What is the antibiotic? Streptomycin with tetracycline. Alkaline nasal douche for humidification. Sodium chloride, bicarbonate, biborate in the ratio of 2 is to 1 is to 1. Lastly, what is the surgery? Young's or modified Young operation. Injection Teflon and Lawton's laser surgery are recent advance. Now come to rhinoscleroma. Rhinoscleroma is also caused by a variety of Klebsiella. It is caused by Klebsiella rhinoscleromatis. Fine. Fine. Klebsiella rhinoscleromatis. You see two very important pathological cells in rhinoscleroma. What are the two pathological cells? One is R for Russell bodies and M for Mikulicz cells. Russell bodies and Mikulicz cells. These are the two characteristic pathological cells of rhinoscleroma. But the nose becomes large in size, it becomes very hard. If you touch the nose becomes very hard and it becomes huge in size, as if it is not a human like nose. वो नाक इंसान की तरह लगती नहीं, it looks like a animal like nose. That's why the terms Hebra and Tapir were given. Hebra and Tapir are actually the name of animals. It is an animal looking like nose, and these two are the images. This is Hebra. Beta Hebra, what is horse plus zebra is Hebra, like mule, Hebra. Fine. Then this animal is Tapir. This animal is Tapir. The nose becomes hard, huge in size, as if it is looking like an animal. Hebra or Tapir nose. That's why these two words were given. Now, beta, in this question, if you read, they had mentioned a word called as hard. That was the only crux of the question. That was the only crux of the question. My friends, remember, don't make a mistake. If in the question they give you atrophic rhinitis wala features, if they give you atrophic rhinitis wala features, atrophic rhinitis features, but along with that they add one word, hard or woody nose. If they add this word, the diagnosis becomes rhinoscleroma. It is a very famous question, very famous exam question, asked many times in NEET PG and INCT also. You have to remember that. Atrophic, but what will happen? 5, 6 lines, 7, 8 lines of atrophic rhinitis they will mention. Only one word, hard or woody. But you will see merciful anosmia, you will see greenish crust, everything you will see, and you will mark atrophic rhinitis, because everything in the question will be atrophic rhinitis wala thing. But only at last they will add hard or woody. Think of rhinoscleroma, because both are caused by which organism? Klebsiella only. Both are caused by Klebsiella, so they show almost the same features. Remember that. And the drug of choice for both of them is also the same. Klebsiella ka what is the drug of choice? Streptomycin with tetracycline. I hope the concept is clear to each and every one of you. Moving on to the next question. It's again previously here asked FMG exam related question only. Fine. A 28-year-old male came to ENT specialist in emergency after encountering a road traffic accident. There was a watery fluid mixed with blood dripping from the nose of the patient, which could not be sniffed back. What shall be not true? Beta, first read the question. What shall be not true regarding the disease patient is having? Option number one, prophylactic antibiotics at higher dose with bed rest should be advised. Immediate FES should be planned. Beta 2 transferrin test helps in diagnosis. CT scan is the radiological investigation of choice. What is the incorrect statement, beta? Yeah, obviously the diagnosis is of CSF rhinorrhea. Most of you would have got this thing. What is the not true statement that you have to think? Which is the incorrect statement? Beta, just to add, the incorrect statement here in this particular question is option number B. 2 attempts or 3 attempts back, the same question came in your FMG examination also. It is a very, very important question, beta. Will you do FES? No, beta. In fact, most of the time, FES, functional endoscopic sinus surgery, causes CSF rhinorrhea, beta. How can you use it for the treatment? Just let us revise the points of CSF rhinorrhea. Beta, trauma to cribriform plate, precisely fovea ethmoidalis, leads to CSF rhinorrhea. You'll be amazed to know 90% of the cause of CSF rhinorrhea is trauma. Which trauma? Surgical trauma. Which surgery? FES only, beta, most of the time. It is the FES surgery, functional endoscopic sinus surgery, or any surgery of nose which causes CSF rhinorrhea. How can you use FES for the treatment of CSF rhinorrhea? Absolutely wrong, beta. Fine. The blood mixed with CSF will be dripping loud, dripping down. It cannot be sniffed back. You see a characteristic target sign or halo double ring sign. Beta 2 transferrin test is the biochemical investigation of choice. Biochemical investigation of choice. CT scan, CT cysternographies are the radiological investigation of choice. And beta, lastly, the treatment or the management is mostly conservative. The treatment or management is mostly conservative. Remember, never make a mistake. Beta, just to tell you, CSF rhinorrhea patients, many times we encounter, the most important thing is just ask the patient to lie down comfortably, little bit head and elevated. Will give cough suppressants and medications to stop sneezing, because if he or she coughs or sneezes, again that CSF channel will open. It is conservative. Give double dose or higher dose of antibiotics so that infection does not go to any brain thing. Fine. Treatment is mostly conservative. Rarely we go for surgery, Hadad and reverse Hadad flap. That is the different era of treatment. But the treatment is mostly conservative. We never do FES. FES to causes it. And this was the same thing asked in your examination. And majority of the student had marked different options. But better, how can FES be planned? FES is the thing that causes it. Fine, beta, FES is never done. Remember, beta, Dr. Javer FES to karta hai usko. FES is not the treatment for CSF rhinorrhea. We do Hadad and reverse Hadad flap. That is a different thing. FES is the cause of CSF rhinorrhea. ठीक है? Fine. Question number 24. Moving on to the next question, beta. Question number 24. A 8-year-old child presents with decreased hearing in both the ears with insidious onset. Pure tone audiometry shows conductive difference of 30 decibel, and impedance audiometry shows a B-type curve. B-type means flat curve. Okay. Management includes all except. You have to tell me the except statement, beta. Management includes all except. Management includes all except. Management includes all except. Think about it. Think carefully. But I am not asking the management. I am asking management will include all except. What I should not do. एक बार पढ़ तो लो बेटा. Read the question. I am asking what not to do. I'm not asking what to do. I know myringotomy with grommet is the treatment, but what not to do is what I'm asking. Yes, fine. Now students are answering it correctly. Yes, beta, the correct option or the thing that we should not do, we cannot do, is option number C, beta. Again, you'll be amazed to know it's a FMG exam question. It's FMG exam related topic question, beta. Modified radical mastectomy is not done in this case, beta. Beta, see, now I'll slowly explain you the question. See, you got to know that the child is a 8-year-old child having problems of hearing, decreased hearing, came with a B-type curve. That means it's a case of serous otitis media. Serous otitis media. For serous otitis media, I'll give nasal decongestants. Yes, because if I give nasal decongestants, eustachian tube will open, serous otitis media is relieved. Will I give anti-allergics? Yes, levocetirizine, fexofenadine, they also help in relieving this eustachian tube, and serous otitis media is relieved. Myringotomy and grommet insertion is the mainstay treatment. But will I do mastectomy? But how can I do mastectomy in an 8-year-old child? Mastectomy is not done before 14-15 years of age, before 14 to 15 years of age. And secondly, beta, mastectomy is the surgery for what? CSOM. Is it a case of CSOM? No, it is serous otitis media. Fine. Beta, mastectomy, modified radical mastectomy is done for chronic suppurative otitis media for a person who is greater than 14-15 years of age. Fine. So mastectomy should not be done. I hope this part is particularly clear. For serous otitis media and ASM, what are the stages and what is the treatment? I'll explain it to you. What are the stages of ASM? First stage is stage of tubal occlusion. The second stage is stage of pre-suppuration. Dr. Javed, most of the time serous otitis media in children is because of adenoid hypertrophy. Yes. Third stage, stage of suppuration. And fourth is stage of resolution. These are the 4 stages of ASOM. Fine. The mainstay treatment is obviously myringotomy with grommet insertion, but apart from that, what else we give for treatment? Antibiotics. We give anti-allergics. We give nasal decongestants. Apart from that, we do myringotomy with grommet. Myringotomy with grommet. Myringotomy with grommet insertion. Fine. Better remember, if adenoids are present, we'll do adenoidectomy. If by chance it is because of rhinitis and there are no adenoids, then we'll do only myringotomy with grommet. Now, beta, one last question from all of you. From this particular topic, myringotomy is done in which quadrant? Beta, remember, myringotomy for serous otitis media, remember, for serous otitis media is done in anterior-inferior quadrant. But beta, for ASOM, it is done in posterior-inferior quadrant. This also you have to remember. Myringotomy in general we do in anterior-inferior. Myringotomy for serous otitis media, again anterior-inferior. But myringotomy for ASOM, acute suppurative otitis media, we do in posterior-inferior quadrant. If you know this fact, fine. If you don't know, remember this also. If your examination question asks, myringotomy is done in which quadrant? Answer, anterior-inferior quadrant. Suppose the question is, myringotomy in serous otitis media or glue done in which quadrant? Again, anterior inferior quadrant. But if they specifically ask Myringotomy in ASOM, acute suppurative otitis media, done in which quadrant? Posterior inferior is a better option than anterior inferior. Remember that. Add, to, add it to your notes. Fine. Fine. With this, moving on to the last 25th question of our 25 most important discussion. Remember, Hennebert sign. What is Hennebert sign? Is a false positive fistula test when there is no evidence of middle ear disease causing fistula of horizontal semicircular canal. It is seen in answer. Basically, Hennebert sign is positive in which of the four options? Congenital syphilis, stapedectomy, glomus tumor, or cholesteatoma? Answer. Hennebert sign. False positive fistula test is called as the Hennebert sign. False positive fistula test. Hennebert sign seen in. Yes, I have got the correct answer now. Yes, beta. False positive fistula test Hennebert sign is seen in congenital syphilis and Meniere's disease. Remember, if you know, well and good. If you don't know, just remember this. Beta, what is fistula? Fistula test. How do we do? We alternatively press the tragus like this. Am I having vertigo? No, because I am normal. It is negative in normal people. But if while doing like this, if I start have, if I encounter vertigo, that means there is a problem, and that is cholesteatoma. But will the examiner ask this thing? Mostly no. What examiner will ask is this: false positive fistula test is seen in Meniere's disease and congenital syphilis. This is your Hennebert sign. And false negative fistula test is seen in dead labyrinth. These two are very, very, very famous. And Hennebert is different from Hitzelberger. Hitzelberger was different, which is acoustic neuroma. That is a different thing. This is Hennebert. I'm again repeating. I'll alternatively press the tragus like this. Am I having vertigo? No. Negative in normal people. If I encounter vertigo, there is cholesteatoma. But what the examiner will ask you is the famous, very, very famous MCQ. False positive fistula test is seen in Meniere's disease and congenital syphilis, and this is your Hennebert sign. And false negative fistula test is seen in dead labyrinth. Remember these things, my friend. With this, we finish the 25 most important session of the subject of ENT. I have no more words to say. May God bless you all. I hope, I wish every one of you pass this exam with flying colors. If you still encounter or feel any doubt, feel free to ask through my Instagram channel, ent_by_Dr.Shubham. Fine. Thank you so much. Thank you for having this patience. I tried my level best to revise the maximum chunk of the subject. I hope I gave you little bit extra bit of knowledge. Obviously, you are having more than me. Thank you. Thank you so much.